the meeting. You're all very welcome. Just reminding members again about mobile phones and Blackberries. To please switch them off. I have no apologies. Does anybody have any apologies? Okay. Just a number of items under Chair's business. Just advising members that the committee will be discussing the draft recommendations on the review of waiting times later in the meeting. I'm suggesting looking for agreement that we do this in closed session as per the normal.
Right.
Prior
to the completion of our report.
Absolutely.
I think it's appropriate. Yeah.
Thank you. Just reminding members also that we had agreed to hold a planning meeting to look at some of the priorities for next year. We want that to take place next week on the 25th of June. The planning meeting will start at 1:30 in the Senate and a light lunch will be provided. The formal committee meeting will then start at 2:30. So if members could endeavour to attend both. Again, for members' information, on Monday of this week I met with representatives of the pancreatic cancer charities and they raised a number of concerns around the lack of public awareness of the symptoms, the late diagnosis and limited treatment options. There was a number of parallels with the ovarian cancer issue in terms of the lack of awareness. I'm suggesting therefore that the committee writes to the department to ask for an update on what progress the Public Health Agency has made. As we will be aware, they are developing a general awareness campaign on cancer and whether pancreatic cancer will be included in that campaign, so I'm seeking agreement to do that.
Great.
Thank you. Also, members, yesterday I met with representatives from Unite, the union. They raised a number of concerns in relation to transforming your care, concerns around the administrative structures within the health service, workforce planning and the use of the private sector. I advised Unite that the committee will be continuing its scrutiny of transforming your care and we'll be looking at this in more detail next week during our planning meeting. Members are comfortable to proceed on that basis. Also, just advising members that last week Fergal McKinney had raised the issue of the Attorney General's role in scrutinising serious adverse incidents or deaths occurring in hospitals or within a health and social care context, and members will be aware this was subject to quite serious media scrutiny over the last while. The Attorney General has given evidence to the Justice Committee, as we stated last week, on this issue as part of the committee's stage of the Legal Aid and Coroner's Court Bill. However, my understanding is that while the Justice Committee has some sympathy with the Attorney General's concern, they did not think the bill was the appropriate vehicle for dealing with them. Fergal had proposed that the committee take a briefing from the Attorney General on his concerns in relation to his powers to scrutinise serious adverse incidents and deaths in hospitals. But before we consider as a committee whether we want to pursue this issue, we would need to be aware that this could become a substantial piece of work for the committee. And I think that, whilst these issues are important in impact, they will involve the department, the 5 health trusts and possibly the board. And I'm just pointing it up to members that if we look at this issue, we could end up spending a considerable amount of time on it without actually producing an outcome. And I know, for example, that the Justice Committee have said or suggested that the forthcoming Justice Bill may be a vehicle for dealing with the Attorney General's concerns. So that could be another avenue for dealing with it. So I'm asking what members' views would be on that. Right.
We're having an overall planning meeting next Wednesday. I think throw it into the mix there, and if we deem it worthwhile prioritising, then we should spend time on it, and if not, we spend time in other areas.
Okay. Are members comfortable with that?
Chair, just on that,
Yes.
Fergal and I know will be away next week for business, so we'll not be here. Personally, I don't think we should get overly involved in this issue. I think, as you were pointing out, it's been dealt with through other forums, and I think it's not strictly our remit, and I think we should be cautious about it.
Okay. Any other thoughts?
Chair, I would concur with that, and I'm away at another event next week as well, so I think our planning meeting is maybe going to be a little bit light on the ground anyways. But I think, if we are laying this upon us with the scrutiny of the new bill that's coming forward, if it ever does come forward, I think anything that is effectively putting concrete shoes on us at the minute would be unwise to go down the road of it in expectation of a very, very heavy piece of legislation coming into this committee in hopefully the not too distant future.
Okay, members, what I'm hearing then is there's a note of caution about the committee actually taking a very active role in relation to this piece of work, given other workloads. So happy to proceed that the committee feel that at this stage that it may be difficult for the committee to take on this added piece of work, but we can reflect on it in terms of the planning date. Is people comfortable enough with that? Okay, thank you.
Great.
Okay, also advising members that the department signed on the Early Intervention Transitional Fund last week. I'm suggesting members that the committee request a copy of the terms of reference for the fund and details of the application process. It's a £30 million process, and I think it would be useful to get a sense of how it will be delivered, rolled out and targeted. Also just coming from the committee's visit this morning to the Cancer Research Unit, I think members are in agreement that was an extremely informative and useful engagement and quite a learning one in a number of ways. And I think there is a willingness in going forward at looking at how the research unit can assist the committee and the committee can assist them. I think one of the sort of maybe direct actions coming from it today would be the issue of the pharmaceutical rebate funding issue, and I think it would be appropriate that this committee sought a view from the department as to how that money is currently directed or used or utilised. I'm seeking agreement that we formalise that to the department in writing.
Great.
Members are agreed.
Chair, can I reiterate what you said about how useful the visit was this morning? And you know, we listened very carefully to the needs and requirements. We were aware to some extent of what was required, but is there any more positive way that we can help to achieve the end? Because I'm sure we're all around the table wanting to see progress made in cancer funding and all the rest of it.
Well, again, I think that this would be the step in the right direction, ascertaining that information from the department, but I do think that it's an issue that we should be reflecting on in our planning day going forward in terms of actions or pieces of work.
Is it normal or is it not normal that we do write and thank them? Because I think the staff on this morning with us were excellent and they took time, patience, and they looked after us very well also.
And I think
so I think we should record our
absolutely,
appreciation
that's a good
and write
suggestion.
to that effect.
Yes, we should do that. Thank you for
Thank
that.
you.
Okay, members, moving on to the draft minutes of the meeting on Wednesday, the 11th of June, which are on page 6. Can I ask our members content with the minutes?
Great.
Okay.
Just agreed to let us.
Okay. Moving on to item 4, which is the evidence session with the Human Rights Commission on the inquiry into emergency healthcare. Folks, you're very welcome. I know John Corrie wasn't able to attend today, but we have Virginia McVeigh, Director of the Human Rights Commission, and David Russell, Deputy Director of the Human Rights Commission. Very welcome. Thank you for taking the time, and certainly with the normal protocol here would be you would give us a 10-minute presentation. We'll then open up to members' comments or questions.
Thank you very much, Chair. And can I pass on again John Corrie's apologies for not being able to be with you. There's an oversight on our part. John had a long-standing commitment on an EU body that he sits on in Brussels. So apologies for that, and thank you very much for the opportunity to appear before you today. When developing its strategic plan for the 2013-2016 year period, the Commission embarked on a new manner of engagement, a new manner of participation and consultation with civic society, NGOs, public authorities and other oversight agencies, which resulted in the 3 pillars of our strategic plan: human rights and good governance, human rights on austerity, and human rights in dealing with the past. The drill down in both the good governance and the austerity pillars called for consideration of health and social care. And the Commission began 2013 thinking about how it would operationalise those issues in relation to health and social care over the 3-year period. One example of the way that we're working is the service level agreements. We have a service level agreement with the Ombudsman for Northern Ireland, and we have just concluded the final draft of a guidance document for Ombudsman on human rights-based approaches to the work of an ombudsman, and that's being showcased to both ombudsman and national human rights institutions globally as a way of working. Another example is the service level agreement with the Health and Social Care Board. We've been providing advice and training around review arrangements for vulnerable adults, regional policies on services for adults with sensory impairments, procurement and other transforming your care issues. However, advice and training is only one element of our work, and as members may be aware, we have investigative and legal powers additionally. Since we opened our doors, the Commission has been running investigations and has carried out a number of investigations that would have touched on health and social care. So, for example, the investigation which was published recently around dignity in nursing homes, and previously in relation to right to life issues. So we'd begun our work on health and human rights a number of years ago, and when we decided under the strategic plan that we were going to look at health and social care, we were trying to think what was the most effective way, in addition to these training and advice routes that we had already been deploying. And there was a methodology that came to mind that we thought would be particularly useful in this arena, which was the methodology of what's called elsewhere in the world a national inquiry. In Northern Ireland, we're referring to it as a human rights inquiry. And the key value of this methodology is that it is centred on public participation and the participation of those involved in any work areas that are touched upon. And so we came to a triangulation opportunity. We had our strategic plan saying that through all of those agencies and the public that we engaged with, that they wanted to look at health and social care issues. We had the issue in relation to this methodology and a participative element. And then we had what area we were going to look at, and given the areas that I had referred to before around nursing homes, etc., and what we were doing with the Health and Social Care Board, emergency health care seemed to be the appropriate place for the Commission to be doing some of its work. And this participative methodology of a national inquiry seemed the most attuned to engaging in emergency health care services. As a methodology, it's been used probably the most in the Asia-Pacific region, and various manuals and training materials have been prepared in relation to the methodology that has been acknowledged by the United Nations itself, and certainly the International Coordinating Committee that sort of oversees all of the national human rights institutions across the world. What I had done to try and give this some kind of life for you is I had taken some of the pages out of the Asia Pacific's manual for national human rights institutions in running these types of inquiries and brought them along today so as you could have a look separately. I might ask them, Chair.
Thank you.
In essence, the way that it works is you scope out a subject area and you do a certain amount of research work. And the heart of the matter is the public inquiry, the public hearings. And with the Commission, we're planning to run, as you'll see in the documentation you were provided with earlier, the public hearings across Northern Ireland in September and October. What's necessary for the format of those hearings are a range of powers within the National Human Rights Institution, powers to compel evidence and witnesses. All of that's in place under the Northern Ireland Act. And then also that we would work with the panel. And the panel in this instance is the Chief Commissioner, we're hoping will be announced very soon, one of our current commissioners, Marion Reynolds, who comes from a social services inspectorate background, and then the former UN Special Rapporteur on Health, Professor Paul Hunt. And I think the presence of Professor Paul Hunt speaks volumes as to the level of interest globally in what we're doing here. It's recognised internationally that emergency services are, as the Chair herself has referred to, as the shop window, the front window into a view of healthcare services within a jurisdiction. And what's been missing very often in review and transformation of healthcare systems is the public participation element, and also for healthcare workers. So our public hearings will run in September and October, and during those hearings we will be receiving evidence from officials. We have requested that Minister, as would happen internationally, would attend and give evidence, hopefully on 2 occasions, at the opening and closing of the public hearings. We are hoping that healthcare workers, as well as members of the public, and indeed the media themselves, who've been very much involved in many of the stories across the jurisdiction and bringing them to the public's attention. And then after the public hearings, all of that evidence will be analysed and a report with recommendations will be produced in the spring of next year. We're a very small organisation with a very small budget, and the way that we will be working is to try and have focus within emergency care. We're not clinicians. We're not healthcare management experts. Our expertise is in human rights. So the focus of this inquiry is going to be around quality, information and participation. And participation in decisions around care and the availability of information to service users are fairly self-explanatory. On the quality issue, the key is going to be responsiveness to need and dignity in care. And we'll also be looking at the skills of staff working in those. That will roll out of it as well. So those are the 3 key areas that we will be working with. In addition to the normal methodology for a national inquiry, we have opened a confidential telephone line. We wanted to give everyone, those working in the healthcare system and those receiving care, as much opportunity as possible to tell their stories. We're also having focus groups, and we're working with community groups across Northern Ireland in advance of the public hearings. And as you could imagine, the sort of stories that are emerging already cover the spectrum of care. We're having mental health issues, we're having issues in relation to children, we're having issues in relation to older people, we're having issues in relation to people who have long-term illnesses and require fairly constant engagement with the healthcare system. So that's a rough outline of how the system will work. We would very much hope to be able to report to this committee. It would be very helpful if this committee perhaps would be in a position at some point to give evidence. And on a further drilled down basis, we would be calling on all MLAs within their own constituencies. We're receiving letters from MLAs already about stories and issues within their own constituencies, and would like to use this opportunity again to ask MLAs if they will help us as a small organisation in connecting with the public. In conclusion, Chair, one of the questions that we have been asked, because of some proposed cuts to our budget for the 2015-16 year, which we have advised create difficulties in relation to fulfilment of the Northern Ireland Act and our statutory duties and our duties under the UN Paris Principles as a national human rights institution. Questions have been asked about running this inquiry. As a very small organisation, we have set aside about £70,000 to do this in its entirety. It was planned for in the way that I set out at the start, from the strategic plan through into our business plan for this business year. So the proposed cuts do not impact on this work. But what I am able to highlight to you is this type of work, which is so vital in terms of engagement and empowering people to claim their own rights and understand them, is put in jeopardy whenever those kinds of proposals are moving forward. But they are not for this year, they are for next year, and it's useful to have the opportunity to explain that to this committee at the outset.
Okay, thank you for that. I suppose by way of commentary, it's probably important to say that this is unprecedented. And I think it is extremely important that we get the overview in terms of the human rights obligations, and that effectively the words that are being used is how emergency care, respects, protects human rights, I suppose, and human rights framework and legislation. So I think it's important to have that sense of it. Particularly interested in your powers around compelling witnesses. I mean, you refer to, for example, that power is there. and you referred to the public hearings seeking departmental and indeed the Minister himself to be in attendance. Can you just elaborate more on that? Is that confirmed?
The Northern Ireland Human Rights Commission is accredited A status within the UN system, and that means that Northern Ireland gets the chance to have its voice heard on the world stage. But the payment for that opportunity for Northern Ireland to have its voice heard in the UN treaty body system is that you have to adhere to certain standards. And some of those standards are in relation to your powers. And so as an A-status national human rights institution, the Commission does have the power to carry out investigations. In order for those to be meaningful, it has the power to, for example, enter places of detention. It has the power to compel witnesses and the production of evidence. As you can imagine, we very much hope that in order that this process can move forward in an expeditious manner, that we would not want to get drawn into long debates. The key here is this is a unique opportunity. It's unprecedented in terms of the attention being paid to emergency services worldwide. And given the reviews conducted by other bodies that are looking at very clinical elements, that are looking at very healthcare management elements, it's a perfect time with transforming your care to make sure that the issues of dignity, which are so crucial to the people going in to use the service and the people who work there every day, become explained in terms of what the legal obligations are. People can use the word dignity, but the question is, what does that mean in terms of weights on trolleys? What does that mean in terms of involvement in your care, or being able to use the toilet facilities or have food and drink? So yes, we have all of the powers to compel, but we hope very much that this will be a proactively participative process for the benefit of all people in Northern Ireland and to enhance transforming your care and the reform of our healthcare services here.
Okay, thank you. And just, I suppose, without preempting, and we can't preempt the findings of the inquiry, we may have instincts and views, but we can't preempt. But if we fast forward to spring of, I think is it 2014?
2015.
2015. Mm-hmm. What will happen with the recommendations?
Well, Chair, they'll be presented to government as all our advices would be and shared, and we would very much be looking for your support. We will present the recommendations as we would with other pieces of work, and then we would be conducting follow-up. And when the various UN treaty body monitoring systems come, for example, the Convention on Economic, Social and Cultural Rights will be looking at the UK. That is where the right to the highest attainable standard of health sits. They will be examining those kinds of issues, and it provides a further vehicle of accountability, and they will be looking to see what government has done in relation to the recommendations of the National Human Rights Institution. So we do provide advice, then it is very much over to government, but because of the UN system and because of the EU systems, then government too will be held to account. UK government has already ratified that treaty and said that from 1976 that the right to the highest attainable standard of physical and mental health is protected in all policies and procedures and practices within the UK. And the question is, how does that measure up?
Okay. And if throughout the inquiry or as part of the inquiry a pattern emerges around neglect or systematic issues that are of concern, and obviously the very serious issues that we've all been aware of around the serious adverse incidents and the reporting and lack of reporting to families. But if the Commission become aware of specific issues that are of concern, do they alert us, the department? What would be the protocol there?
Well, we have a process of escalation. We as a public authority ourselves have duties under the right to life and the right not to be treated in an inhuman or degrading fashion, and we must escalate those risks ourselves. Dr. Russell can speak to an example with our nursing home report as to what we did there to provide assurance to the committee as to having worked with this before and having escalated matters before.
Yeah, could you, David, just
The
maybe...
internal process for previous investigations is exactly the same as we'll follow here. It's quite simple, not to take a lot of time up from the committee. There's obviously regulation and inspectorate bodies that already exist within the healthcare system. And so the Commission's first point will be, if it's a systemic issue and it's happened historically, the Commission may not escalate immediately. We might hold back on that evidence, having taken our own mind on it, and that would go into our report. But if it's a case of an individual, for example, where we receive a complaint that is in the immediate here and now, and the Commission is of a view that either there's an ongoing breach of that individual's human rights, we'll send it to the relevant body responsible and ask them to act immediately and to come back to the Commission immediately as to what action they have taken, so that we are satisfied ourselves that the proper process is being followed in terms of protecting the individual concerned.
Okay, that's
It's
clear.
unlikely with regards to an individual case, I have to say, that we would report back to the committee. But certainly when it comes to systemic or potential systemic abuses or violations of human rights in the longer term, we'd be very much engaging with this committee in terms of our view as to what would be necessary actions by either the department or the relevant trusts or authorities in order to rectify that wrong.
Okay, thank you. Thank you for that. I have a number of members had indicated. Kieran first.
Yeah, Chair, that was a question I had, but you sort of answered it there. The other one is, to what extent will the particular issues faced by patients with learning disability, and you mentioned their mental health conditions, would they be taken into account?
Well, they will, under the heading of quality. There's a sub-point on responsiveness to need, and that's in because we want to look at particular vulnerabilities. Now, if you start to list all the particular vulnerabilities, it's a bit unwieldy, but yes, absolutely. We have already had information, by way of example, from adults with sensory impairments, and some of the difficulties that adults with sensory impairments face whenever they go into a waiting room in emergency services, and how different issues in relation to sight, where people have been told to press certain buttons and whatnot and wait for people, or where there's a hearing difficulty in terms of knowing who to approach, and then the response that they receive. So absolutely, it'll be vital.
The other thing as well is, as part of the methodology, the Commission we're obviously taking evidence through our confidential phone lines, but our staff team working on the investigations are also engaging directly with groups of people. In the Commission, in all of its work, our focus is always on the most vulnerable and marginalised. That's our starting point. So, for example, in looking for the evidence base from the trusts, policies and processes around vulnerable and marginalised groups would be something very much that would be to the forefront of our mind, including those with learning disabilities.
Yeah, okay, that's fine. Thanks, Chair.
Okay, Mickey.
Yeah, thanks very much for the presentation. Obviously, with the public meetings, there's one in Uri, I think, in September. They will be advertised locally in press and presumably, possibly local radio, that kind of thing. And it'll be well advertised because obviously you want as big a participation as possible.
It's absolutely crucial to us, and we are small and we do have that very tiny budget. What we've done this week is, as well as the, and we're sending them out to all MLAs, so you should receive posters like this one. It has been in the main papers, I think that was last week, but it's in all of, or the vast majority of local papers this week. And what we have also put out are the timings for the public inquiries, in order that people have that kind of information in advance.
I'm thinking of near the time because obviously if it's out then it's in September,
Yes.
you know, so that's one question. The other thing is obviously there's a free phone telephone line, and you're talking about family members, patients and healthcare workers. Now obviously that opens the door for whistleblowers, because that has been part of the recent culture, I suppose, for want of a better word, and rightly so, if people feel that it's the only way that they can get their message across. Now, I presume you're going to get people phoning in with who are in particular circumstances, and I know it will be confidential, but will they be treated, I suppose, any differently in a sense? Because you're going to have people who are very well placed within the healthcare system who see systemic failure or see particular failures in terms of what has happened in particular episodes, maybe in an A&E unit, that kind of thing. I'm just wondering, is that something that will, I'm sure it will be factored in, but it was just a maybe.
Yes, people should feel very confident in approaching us, not
Suppose that's
least
the case.
because in terms of whistleblowing, the Human Rights Commission is a recognised agency. We want people to tell their stories, good stories, about how it worked well for people, but also we recognise that people may feel very anxious indeed. We have been approached by healthcare workers, but we've been working very closely with unions, especially Unison, to make sure that we have all the systems in place that their members can feel confident and comfortable in approaching us. We also will have opportunities for some evidence to be heard in camera if that's deemed necessary. Obviously, the whole point of the process is to be as open and transparent as possible, but those situations may well arise. I don't know if there's anything you want to...
Just what Virginia said, the Commission is a designated body under the relevant legislation, so individual staff members who come forward to the Commission or whom MLAs may have been in contact and would want to direct the Commission to be perfectly assured that they can afford of the protections under the necessary legislation in terms of whistleblowing. And we understand that that takes immediate effect from the point of time that they come to the Commission, and we would act very much in their defence in that regard. With regards to senior clinicians, for example, who might have evidence, there's a slightly different tact with regards to how the evidence comes to us. If some senior official is forthcoming to the Commission of their own accord and wants to be afforded that level of protection, then the Commission would consider in terms of whether it's necessary, as Virginia said, to take evidence in closed session if need be. But it's not the ideal for the methodology because it's in public. And the reason why I say that is there will be a distinction between public officials who are called by the Commission to give evidence and those who come forward of their own volition in order to provide evidence to the Commission. It will be the expectation, and the Commission is unlikely to deviate from requiring public officials to give their evidence in public before camera and the media, it will be open at the public sessions for them to be there.
And that was the next question, I presume, in terms of advocacy for those people who may feel that they need it. Obviously, unions are involved, but also that they won't be compelled necessarily to give that evidence in public if it's deemed that it may be have an adverse effect on the person in terms of employment or whatever, but the unions will be factored into all of this, presumably.
We have done that. In addition, there's a pilot project been operating through DOJ around advocacy and vulnerable witnesses and whatnot, and we have actually been liaising with that project in our development. We don't have sufficient staff to match an advocate to each individual, but the evidence will be planned beforehand, so we will know the people coming forward to the public hearings in large measure, and we will be able to provide them as much support. And if we came across a situation where we deemed that the level of support that would be provided couldn't be made for some reason, always the interests of those individuals will come first.
Thank you.
Thank you for that. David, next.
Thanks, Chair, and thank you for your presentation. I just wanted to get maybe a bit of a better understanding just around the fibre of the report and sort of what it's possibly going to look like, obviously, at the other end. What health-related research and work has the Human Rights Commission been involved in the past? Is there some sort of recent examples of other pieces of work that you've done around health?
Well, I was trying to remember as it was coming up. I would say it is at least 7 years ago, and I hope that's close enough to not be too far out. About 7 years ago, the Human Rights Commission held the first conference on health and human rights. It was fairly groundbreaking, even within the UK. And that was, in fact, one of the earliest occasions when the UN Special Rapporteur, who was then in post, Paul Hunt, had come over to Northern Ireland to have the opportunity to explore the connection between human rights and health. Following that, there was development within the public authorities themselves to try and pay closer attention because equality had been the key issue. So we had looked at it there. We'd done a lot of work around the right to life. We had, for example, worked Senior QC Tony McGleenan around death investigation. We'd work closely with the Senior Coroner around what is required and the connection between the healthcare examinations within the system and the inquest procedure and criminal procedures. So a lot of work around the right to life. Then, as a further development, when we were looking at nursing home care, we were very much into the realms of dignity and exploring what that meant in real terms by applying the human rights in the quality of people's lives day to day and the dignity and the care that they received. So in all of those key areas, and in rights terms, that would mean the right to life, inhuman and degrading treatment, and the right to a private and family life, which is very much where sometimes I describe it as the sin bin of human rights. If you're not sure where it goes, the right to a private and family life is very often the place that you would go to. It's really about your opportunity to develop as an individual and all that that might encompass. So in all of those areas, plus in relation to the treaty body monitoring system, we have to advise the UN in relation to the UK state reports on a range of civil and political rights and in relation to economic, social and cultural rights, and that has been ongoing since the Commission came into operation.
Okay, thank you. So bringing that up to date in this report, because and I say this with the greatest of respect, because I'm curious to see the outcome of this report as much as anyone else is, but I suppose we are no strangers in this committee to having a list of problems brought to us. However, what we're not so good at getting is a list of solutions. And I suppose what we're trying to, I've seen in the calls for evidence that you're taking and the groups that you're calling for, I think it's probably fair to say that you will get a fairly significant response, all of which, whenever we're dealing with staff, patients and unions who will have particular grievances, and which they have many ways to put across, and your report will be just one of many. What will be done internally from your point of view with the necessary expertise in order to ensure balance in the report? Because I do see a list of people who I could probably, and groups who I could probably predict quite accurately what their responses are going to be. And I'm sure, you would be very passionate about the fact that every report that is published has to have a degree of balance. Have to look at all of the if we take, for example, the 9th of May, Jim Stewart, who was the former chair of the Northern Health Trust, described the Northern Ireland healthcare system as third world. Now, I've visited at least 2 third world countries and in hospitals as well. I've also been an inpatient in hospitals in Northern Ireland. I know where I would rather be an inpatient. But I think the benchmarking from that statement is wildly wrong. So what are we going to do to make sure that, I suppose, and we're in a privileged environment here, Mavericks don't come forward with scurrilous statements of criticism, unjust statements of criticism against the health professionals that are working very hard day and daily. How are we going to make sure that that balance is in the report once we get to the other side?
Okay. You've, in your question, you refer to 3 things. You refer to bring me the solutions and not the problems. You talk about how you're going to deal with balance, and you ask about benchmarking. So in relation to the solutions, what I would give you there by way of example is, even by the way we're setting out to do this inquiry, it is as solution-focused as an institution such as our own has the statutory remit to be. In looking at dignity, the solution we're bringing is that we're not simply going to say people need to be treated with dignity. How does that help us by simply telling the stories when we didn't think that they were treated with dignity? It is our job as the National Human Rights Institution to bring you the law and say this is the point at which we think, in terms of the right to dignity and inhuman and degrading treatment, we're into the area of breaches and violations. This is where we think there is a difficulty. This is the bit that needs to be the priority in terms of solutions, because otherwise you have the possibility of a scattergun approach. So our job here is to apply human rights in a meaningful way so as the decision makers can prioritise and make the decisions that they have to make in terms of advice on process. Balance. A lot of human rights discourse is about balance. It's our job to tell you what's absolute. It's our job to say, at this point, in terms of inhuman and degrading treatment, it has gone over the line. And there is no balancing job to be done in terms of the legal obligations. At this point, it's into breach. And there is no other competing right that can knock that out of that zone. But when you talk about Third World, one of the great benefits to this particular project is having Paul Hunt, a special rapporteur. He was key in addressing issues around maternal morbidity and infant mortality rates in the developing world. He has worked there extensively, as well as in the developed world, and he understands the comparisons. What he likes to be able to unpick and provide advice to government on is the difference in that if the bar is here for a state to progressively improve the right to the highest attainable standard, they're working up from there. That is different to where the bar has been set by the state within the UK, and we have to work up from that point. But he is probably more aware than anyone else who may be in the room at any time about how that compares to the rest of the world. And finally, on benchmarking, again, having that international input, it's our job to look at the benchmarks already set in law. It's not our job to aspire to new benchmarks or create new bucket lists of what we might like. It's going to be purely based on the law and the legal obligations as we unpack them. So those will be the benchmarks as opposed to any other aspirational notions, and they'll be rooted in human rights law. We won't be able to transgress into areas that might be more clinical, although we will be taking some clinical advice as required.
Thank you. Thank you.
Thank you, David. Roy?
Again, thanks for your presentation. Just for clarity, which of the 30 articles of the Universal Declaration of Human Rights is your inquiry focused on?
Primarily, to be honest, we're focused on the economic, social and cultural rights, Article 12 and General Comment 14, I think that it is, in relation to the highest attainable standard of health. You'll catch me out in the Universal Declaration if I'm having to go through the list. It's mainly issues in relation to dignity and the right to life, but primarily in terms of, because the Universal Declaration is not in itself a legal document, but nearly sets the scene for the civil and political rights and the economic and social cultural rights that fall beneath. Those are the ones that the UN treaty system examine. And maybe David's going to be smart and be able to tell you the
I'm just going to be
numbers.
very direct and say we're not focused on the Universal Declaration of Human Rights at all. It's not a binding treaty. It's simply a direction.
Yeah.
So it's not binding on the Northern Ireland Executive. It is only a declaration. Our primary treaty will be the Covenant on Economic, Social and Cultural Rights, which includes the right to the highest attainable physical and mental health.
For information, what covenant?
The International Covenant on Economic, Social and Cultural Rights,
Has the UK signed up
which
to
the
that?
UK has ratified and which is binding on the executive under Section 26 of the Northern Ireland Act.
The next question is, you said this inquiry will cost about 70,000. Does that include staff costs?
No, it doesn't. We have a very small.
What estimate would you have of the staff costs associated with it? I mean, how many of your staff will be committed over that 6 months, year?
Well, we probably have 2 key staff committed to it on a permanent basis. We have a project lead in the legal team, and we have a research lead. So it will not be the entirety of their time, it will be part of their time. If you were to make a rough stab, you'd be talking about, in terms of allowing for a part of their time, £60,000, but these are sort of estimates.
I think it's sort of been accepted by most people that much of the health difficulties is the mismatch between resource and the pressures and the demand. And your inquiry is focused purely on the acute sector. Why have you not included the primary sector? Because are there too many people going to the acute sector, which is causing the problem? Or is there sufficient GP out of hours service? or is there sufficient investment in preventative health care? So you're only looking at one element of it. Why did you decide that?
It's not, the issues that you identify are very likely to come up within the inquiry itself. If you effectively go to, let's draw it as accident and emergency, there are routes into accident and emergency and then routes out, and it will be a necessary part of this inquiry to take those into account. That said, because of the size of our organisation, the terms of reference are very important, and it would be, I imagine, very easy, and on a number of occasions we're likely to be pulled in the direction of mission creep or going down other lines. But the issues that you identify, particularly GP out of hours, are likely to be very central to the process.
And finally, it does strike me that overworked, overburdened staff in crisis situations have frequently been concentrating on the next firefighting whose life is at risk, and then the issue of dignity, of course, with others can fall. So my question is, to get an outcome of this, essentially we need more health resources, but given the fact that DUP and Sinn Féin, the lead parties, have refused to provide additional health resources as part of the budget, where is your process going?
Well, we're not starting out with an assumption that this is all resource driven. I think in terms of the advice that we have received internationally, and you could have locally, not everything is dependent upon resources. Certainly a good deal of decision making is decided upon prioritisation, and under human rights law, the right to life and the right to be free from inhuman and degrading treatment are both operate to all intents and purposes as absolute rights. So it isn't possible to decide in terms of dignity, well, have to fight this fire, therefore the dignity issue has to go to one side, and that'll be part of the message that we bring across, that it isn't possible under human rights law to let dignity slide and then explaining what we mean by dignity. I have no doubt that the issue of resources may well arise, but decisions in relation to prioritisation in our health and social care system, then that becomes a matter for the democratically elected representatives to decide. And then across the budget as a whole, again, human rights is looking for a democratic system, so that becomes a matter for democratically elected representatives to decide.
Okay, thank you.
Thank you, Roy. Fergal?
Thanks very much, and thanks for your presentation. I'd like to follow on from a point from Roy, but in a wider sense. It's always been our view, that the SLP view, that is, that the action emergency thing is basically a symptom, not a cause. And while Roy is suggesting looking at other dynamics, for example, GP, we believe that, you know, the change agenda itself has potentially led to some of the dynamics which are causing problems. So will your narrative include that, or will it include any evidence, if you like, pre the introduction of PYC as a comparator to the situation now, an assessment, if you like, of the veracity of Barclay, without wanting it to be an assessment of our view, but in the context of your inquiry?
Well, I hope that the view of the SLP is voiced in the inquiry. I have, in order for this to make sense as a self-contained document, both in Northern Ireland and anywhere else in the world, we're going to have to put it in context. So you're going to have to be able to read, this is how we came to this position, this is what's current. So I think necessarily that context and transforming your care will come into play. The notion of how it impacts on the rest of the system is probably something that's very much going to come up in the evidence, and I would say particularly the evidence of healthcare workers and government officials as to where this sits within the overall system, because those are the people very often best placed to tell that story. We think it works like this, for good or ill, because, for example, we think there's a difficulty in relation to older people being in accident and emergency for too long because we can't get them admitted quickly enough, and there may be another process by which to admit people. Or we think there's a difficulty in accident and emergency because people with long-term illnesses are having to wait there when we already know that they will have a need and that they will be coming back time and time again. So I very much hope that in the evidence presented by political representatives, healthcare workers, in the main, they will be telling the story with as much of a whole image as they possibly can.
And it's just that I've identified a potential flaw that's clearly articulated by yourself. You were saying, that one issue gets subsumed in another process, and if we end up with dealing with the A&E issue simply on a rights basis, that the authorities try and respond to the rights agenda within that, consistent with your report, if we ignore the wider dynamic.
Well, I would hope that it wasn't a flaw, but rather the genius in the plan is to say, if you look at accident and emergency and you talk about what dignity means there, just like when you talk about what dignity means in a nursing home context, it doesn't necessarily have to dramatically change with each environment. So whether you would be talking about care in the community, with domiciliary care or acute care or long-term care, these issues of dignity apply across the board. So of course we only have one lens, one tiny lens to look at it, but there's absolutely no reason why strategically those lessons couldn't be applied elsewhere, so that the lessons from the nursing home care report in terms of quality of life and dignity could be equally applied into a domiciliary care setting. And we're very much hoping that the Health and Social Care Board and RQIA and others will take it as key standards to apply in all sectors of care.
Okay, thank you very much.
Thank you, Fergal. Gordon?
Thanks very much. Thanks for your presentation. Could you clarify just why you've selected health and why health at the moment? Is to be just wanting to add to the whole plethora of media attention that health has got? Are you just trying to get on the bandwagon? Is that what it's about? Or can you clarify why we're going for health?
I think in some of the answers that we've given previously, this really has been a developing area over many years, as you'll be able to track in terms of even the annual reports of the Human Rights Commission.
It's 7 years, you said earlier, since their last.
Yeah, well, no, not since the last one. Since we began very particularly looking at health and social care with that conference, for example, and then a number of other reports. We do have a very broad remit in Northern Ireland. There has been a lot of focus on prisons, immigration status and services. We have looked at we've looked at a wide range of issues, and in terms of the feedback that we got in our strategic planning process, health and social care came up time and time again, and we listened to what the public and government officials, civil servants were saying to us, and we built that into our strategic plan. So having had it in our strategic plan, having then had it in our business plan, the bandwagon effect didn't come into play. As it happens, all of those media reports have been coming out, which really only copper fastens that we were right to listen to the public when they said to us, we want you to look at health and social care issues such as the nursing home report. That was the overwhelming feedback we got after the publication of that report.
The Commission also has other work ongoing at the minute in the area. In the next year, we'll publish a major research report on the rights of carers, focused particularly on those who care for children and older people caring for adults in their family. So we're looking at that from a health and social care perspective as well. We also share with the Equality Commission, we're the designated independent monitoring mechanism for the Convention on the Rights of Persons with Disabilities. And the UK will be examined on that treaty next year for the first time. So the Commission is very much looking at health and social care in that aspect of our work. The other thing is the current cohort of the Commission has made a point of at least once a month going out to local communities throughout Northern Ireland. And I think it's fair to say, because I have been with them in many of those visits, that has helped set our strategic plan and our business plan. Two things have been repeatedly called from members of the public for the Commission to look at in the public interest. One has been health and social care, and understandably emergency care has featured quite highly in those discussions. The other area is poverty in an age of austerity. And again, the Commission is undertaking a significant piece of work in that. Those two recurrent themes, when we have asked the public, what is it that the Commission should be doing for you? What human rights do you think are central to the lives of people living here? Repeatedly, it's health and the issue of poverty.
Were you encouraged by outside groups, agencies to get involved in this study? Are we asked to come in and do the study?
No. Not least because under those Paris principles that I referred to before, we must act entirely independently. The way that we deal with the listening is, as David has described, both through our community engagements and through that strategic planning process. We also run legal clinics in Northern Ireland, and again we see if there are any patterns emerging from that, so as we can deal in a more effective and efficient way with any systemic problems there may be.
Just a matter of interest, did you give evidence to Transforming Your Care public sessions at all, your organisation?
No, we had engaged. I don't think that we were in the public sessions because I had met with John Compton on a number of occasions, and we were asked to deliver a masterclass to the Transforming Your Care team. And with that also then the service level agreement with the Health and Social Care Board. So we were trying to be as practical as we possibly could, which would have then been inappropriate arguably for us to sit in a public session and take up other people's time when we had those routes in.
But you did take up the opportunity to
Yes.
have an input into Transforming Your Care. Okay, you obviously recognise, and I grow, made the point about the huge workload, the demand that there is on the health service. So, and again, on balance, how are you going to ensure there is balance against the constant outcry that there is about from certain people about the health services? Again, the recognition of the huge amount of people that go through, the volume of work that goes through the health and social care services at the moment, and the vast majority of people go through. Well, we know from our constituency offices, we get complaints mainly about getting into the service. But the majority of people once they're in the service are satisfied. And are satisfied with the service. In fact, they're very positive. They get back positive feedback about the standard of care from the health professionals. So, again, I think it's important you address that balance. And how do you hope to do that?
Well, because this is focused on a public participation methodology, it's to try and encourage everybody to tell their stories. We've been very clear in all of the media work that we have done to date and in anything that we're putting out that it is all of the stories in order that we get a balanced report.
Including positive feedback?
Absolutely. It's really important to
Do
be
you
able
do
to
positive
receive that.
feedback? You do?
We do positive
Oh, that's
feedback
good.
all the time. All the time. The
encouraging.
whole idea is if somebody has a really good system that's operating within one trust, it's to share as much of that good practice as we possibly can and to tell those good stories. And we know whenever we've been engaged in whether it's around nursing home or domiciliary care, the stories that you hear in terms of the unsung heroes who went out in the snow and went and got somebody a cardigan in Abbey Centre, and those are there. In terms of the business and what we have a statutory duty to provide to government, it's not necessarily to provide all of those stories because we wouldn't really be being as effective and efficient we could. But yes, in terms of this, it's absolutely vital and would want to use the opportunity here and anywhere else that we get to say, please come and tell us the positive stories, the good stories, and particularly share good practice.
The other thing is, in terms of the public hearings, the Commission won't just hear witness testimony from those who have come over the confidential telephone lines in order to tell a bad experience of what has occurred. The Commission will also call those to give evidence who are in positions who may have a completely different view on what the reality of healthcare is in terms of emergency services. And generally, with regards to our operation, if you want to get a sense of the sort of report the Commission will produce, members might want to look at the recent investigation report on racist hate crime, and there you'll see the tone of a Commission report. It does identify bad practice or a lack of compliance with human rights standards in part, but it very much also recognised good work by police officers, policies by the department that were fulfilling human rights standards, and in some instances went beyond what the minimum core obligation of the state actually required.
Okay, just finally, the Trust Operating Complaint System, which we all use and we put cases through there from our constituency offices. Will you be looking at those, the process and the procedures as part of this, and get some feedback on how they manage those?
I think it will be important in terms of the evidence provided by the trusts around the quality of care and participation and information as well. that they provide evidence on that. We have a long list of documentation and materials that we have requested through the department and then through the chief executives of the trust, and we're waiting for those to come in.
Okay, thanks very much, folks.
Thank you.
Thanks,
Okay,
Chair.
thank you, Gordon. Just, I suppose, just a few questions that were occurring to me as you were speaking. In terms of the confidential telephone line, what kind of, is there a sense of uptake?
There is. It's interesting, given the last comments, we certainly are getting very dramatic stories coming through. And as you can imagine, with a confidential telephone line, and we had anticipated ourselves that it was important to provide that service, we thought. But it is much more likely that people will be motivated by. So we have had good stories coming through, but the percentage of those is, they are by far the smaller proportion of the stories. So we wanted to have that service available, but it's really important that other people come through and tell their stories. They may not be life and death stories, they may not be horror stories, but just what was your experience, in order that we get that spread. And we will be doing those through, as David says, focus groups and community groups. But we would also encourage people to use that telephone line to tell their story, whatever their story is.
Okay. And in relation to the work that was done around the 10,000 Voices report, are you utilising that work? Will we? Or?
Yes, we've been working very closely with Patient Client Council in the scoping and development of the inquiry, and the 10,000 Voices will form a part. That's a huge collection of stories. They're not all about emergency services. They're obviously across the system, as it were, so that will feed into it as well.
Okay. Okay, and I suppose just to say, by way of conclusion, to thank you both. I think it has been useful, I suppose, on 2 points, to get the sense that the focus is on participation, because I think, that can be missing quite often in terms not only of health, but we're dealing with health, and sometimes ensuring that focus, that the person is central to the process as well, is important. And I think also you've been very clear that to the context of this piece of work in relation to your strategic plan going forward. And I think it is important for the committee to reflect on the universal principles, the fact that, dignity goes across the piece, and how then a piece of work like this can actually put the legislative framework to that concept of dignity and underpin it. So I think that's important. So wish you well. We'll continue. Oh, sorry, David.
Sorry, Chair. I thank you very much, if you're indulging. Just one tiny point I just want to clarify. I echo everything the Chair's just said. But, Virginia, just in response to Gordon's question, you're absolutely crystal clear that this report, this specific report, was instigated at the behest of the Human Rights Commission and was not as a result of a request from either within or without this committee.
Yes.
Absolutely crystal clear on
Yes.
that. Okay, that's fine. Thank you for that.
Thank you for clarifying that. I think I just want to thank you. We look forward to the work continuing. We will reflect, I suppose, within our remit, how best that can be, the work that's ongoing that the committee are doing in relation to TYC can support and enhance the work that you're doing. So thank you for taking the time today. It's been very informative.
Thank you very much indeed, Chair, members. Thank you.
This is the Northern Ireland.
4. Okay, folks, you're very welcome. We have Catherine Daly, Deputy Secretary, Healthcare Policy Group at the Department, Mr. Chris Stewart, Director of Healthcare Transformation, and Sean Donaghy, Director of eHealth and External Collaboration Health and Social Care Board. So you know the format, 10-minute presentation. We'll open it up to comments and questions.
Okay, thank you very much, Chair. Well, my colleagues and I welcome this opportunity to give evidence to the committee about the Connected Health Agenda and its importance in improving public health and wellbeing in Northern Ireland. We've provided a briefing paper to the committee on 10th of April, and that paper outlined the background and the policy objectives of the Connected Health Agenda, and it outlines some of the key areas of development under this agenda. So what I will do now is just briefly summarise the key points. For the purpose of this session, it's worth highlighting that the agenda we cover is more than just connected health. It also covers e-health, and the key distinction here is that connected health is about using technology remotely to improve patient and client care, and e-health is wider, and it's about the use of information which is needed by people and care professionals to make better decisions about prevention, treatment and care. This includes information held within our systems, information generated by diagnostic devices such as X-ray equipment, self-monitoring devices and sensors, and the use of this information can be made easier by ensuring we use the right standards and technology to allow information to move between systems. This means it can be shared appropriately between people and organisations to support care. Northern Ireland has the unique advantage of having an integrated health and social care system, and we use the phrase e-health to cover both health and social services under this agenda. The continued development of this agenda will be a key contributor to the future sustainability of health and social care services. And that very point was recognised in Transforming Your Care report in 2011, which highlighted the importance of technology as a key enabler in the new model of care. Effective development of connected health can support patient choice. It can shift the focus from secondary to primary care settings, and ultimately the delivery of more cost-effective and higher quality health and social care services. As regards the impact of the Connected Health Agenda on frontline services, one of the key strategic developments within the past year has been the implementation of the electronic care record. Early indications are that the electronic care record has led to a reduction in unnecessary appointments and repeat diagnostic testing, improved medicines management, less movement of paper around the service, and reduced delays while waiting for the right information. The telemonitoring programme is now in its third year of operation, and telehealth through Telemonitoring Northern Ireland Managed Service has to date benefited more than 3,000 patients across the region, and these numbers will further increase during the period of the telemonitoring contract. We continue to make telecare services available to patients to help support independent living, and during the last financial year, approximately 2,500 patients had the service installed in their homes. All of this represents good progress, but we absolutely acknowledge there is still a lot more work to be done to fully embed the service into patient care pathways. A research evaluation on telemonitoring is underway, and the outcome of that work will be reported on next year. Across individual trusts, we're seeing a range of excellent innovations. Technology is being used more frequently to facilitate communications between clinicians and patients. Looking to the future, the health and social care sector will be working to maximise the benefits from existing investment, and there will be a focus on integration and interoperability, joining up data across systems and services to allow information to follow a patient throughout their care journey. We foresee a growth in the use of mobile technologies to enable clinicians to access patient information as they move within and between locations. And all of these innovations go to the heart of the transformation agenda, building services around and supporting the empowerment of service users, giving professional staff more time to spend with patients, and enabling appropriate care to be delivered in the right place at the right time. There has been excellent progress, and the health and social care sector is well positioned to continue to maximise technological advancements in support of service modernisation. And the e-health and care strategy currently being developed by the Health and Social Care will set the direction of travel between now and 2020, and we expect that strategy to be issued for consultation later this year. The potential for connected health research, development and innovation to generate economic growth is also a recognised element under this agenda, and it forms a key strand of the agenda. Members may be aware and recall that a Memorandum of Understanding on Connected Health and Prosperity was agreed between Minister Poots and Minister Foster, and it's directed towards maximising both health and economic gains under this agenda. And the advancement of the work on the memorandum is overseen by Connected Health and Prosperity Project Board, which is chaired by the permanent secretaries of the two departments. And that memorandum is underpinned by a strategic action plan. It would be fair to say that over recent years under this agenda there has been considerable energy invested in raising Northern Ireland's international profile in the connected health arena, and that's been particularly the case in Europe and in North America. Northern Ireland is a small region, and while that gives us many advantages in terms of the ability to adopt innovative practices, it is also recognised that there are significant gains to be made by collaborating with others. And we've seen in the course of these engagements that while there are different systems in place across Europe and further afield, the issues that the health systems are facing are common throughout in terms of the growing and ageing populations, increased prevalence in chronic conditions and financial constraints. So we're all dealing with the same issues, and therefore there is that opportunity to learn from each other and for us to share our learning with other regions. In that context, last July we were one of only 13 reference site regions who were awarded 3-star reference site status by the European Commission. That was under the European Innovation Partnership on Active and Healthy Ageing, and that means that we're now recognised as one of the foremost regions in Europe in bringing about a high standard of care for our older population. We've also been proactive in developing alliances with regions across Europe where we have identified areas of common interest, and memorandums of understanding have been agreed with the Basque region and with Oulu in Finland, and a number of other memorandums are currently in development. And these developments have placed Northern Ireland in a very strong position to avail of European funding opportunities. We're currently participating in a number of applications under the Horizon 2020 programme, and the ones that we're currently engaged in, and that's just the start of this process, if successful, will secure some £2 million funding from Europe to progress various elements of the connected health work. The Minister has also recently agreed a memorandum of understanding on e-health with the New York State Health Department, and that will enable us to progress various strands of work emerging from the Task and Finish group that was set up under the Executive's Economy and Jobs Initiative. That was set up last year to assess the economic potential to be derived from the health and social care sector. And since the group was, since the Task and Finish report was published last May, there has been steady progress in scoping and taking forward their recommendations, and an implementation advisory group involving a number of technical and expert industry advisors is now in place to assist further in this process. So, Chair, I'm afraid that's a bit of a gallop through what is actually, you know, a very wide and developing agenda, but I hope it's given members, you know, a summary of where we are, and we're happy to answer any questions that you have.
Okay, well, thank you, Catherine, for that, and obviously it is an important agenda for us all. I suppose, really, a number of points. The work around the Horizon 2020, you said there's an application of be to a value of £2 million. You know, is there more detail on that? And specifically, to do what?
Just to say a bit about the Horizon 2020 programme, and I'll hand over to Sean on this, but I mean, that is a massive programme. The Horizon 2020, the funding under that is €79 billion, so it's a phenomenal amount of money. There's not a single health strand in that, but there are a number of strands within that programme that have health elements, and Sean be able to provide more detail on that.
Okay.
Well, thank you, Chair, and thank you, Catherine. As Catherine mentioned, there are a very large number of individual calls which Europe issues under the Horizon 2020 programme, and that's a rolling process and will continue right through to 2020. So that 79 billion that we've referred to is a 7-year allocation of funding over that period of time. There are a wide range of applications that we've made to date. We've had some success within health and social care in drawing down funds from Europe. Core to their objectives are using mechanisms to better integrate information and to better support the citizens by promoting measures that help citizens to be independent with a focus on technology, because it's also about generating jobs. Some examples include a project that we're working on with colleagues in Spain, Croatia and France around looking at chronic heart failure and COPD and finding ways in older patients to use long-term patient data to improve the quality of interventions. Another is a programme where we're working with Italy, with Edinburgh, with Spain, looking at new models for delivering integrated care to children with special needs and comparing how those models work in different jurisdictions and seeing what can be done to develop best practice models and determine what's the most effective way to support those children. I could go on, Chair, but there's a large degree of variety amongst the nature of the bids. I'm very happy to provide the committee with further detail. We have that detail available if you would like to have
that might be useful as it moves forward. Specifically, the memorandum of understanding signed with Derry. Is there, because I mean, this is obviously connected health, e-health, but it's also about innovation and the economy. Is there a job specific target in that MOU, and is it been advanced or progressed, or is there any update on that?
Well, under the that particular memorandum, we have established the Connected Health and Prosperity Project Board, and there's the Task and Finish group that was set up under the Executives Jobs and Economy Initiative, and that is then working under the auspices of the CHAP board under that memorandum, so it all comes together. In terms of job specific, yes, the Task and Finish report, there were a number of recommendations, I think 6 it was in total, and one of those is very much focused on skills in the health and social care sector, and the need for development of skills in relation to the transformation programme. And clearly there are issues there if we look specifically at domiciliary care sector, and so that is one of the issues. That's just one, but really the whole jobs aspect of this spreads right across that agenda, because I suppose one of the starting points there is that in terms of looking at the expenditure on health and social care services, there's £4.5 billion spent there each year. That in itself is an investment, because as well as delivering health and social care services, that's an economic investment in terms of jobs. It's the biggest employer in Northern Ireland, with 60,000 staff across the region. There is a strategic action plan set up under the memorandum, and within that, the part of the actions there are to identify research and development priorities and the implications there for near market research and development, and the jobs implications in terms of that. And also on the Task and Finish report, there are very job-specific elements of the recommendations there. Chris, can you say a wee bit more about that?
Chair, there isn't an overall target per se of additional jobs to be established, but as Catherine said, the report recognises the vast potential of that £4.2 billion of investment each year. The two areas where I think that will have the most significant effect are, as Catherine has said, specifically around ensuring that we have the skills and the competences within the HSC workforce and the independent sector to deliver the transformational care that we're looking for, but also recognising in the field of connected health that the sorts of new technological solutions that will come forward to address health and social care issues provide real opportunities for small to medium-sized enterprises within Northern Ireland. One of the examples that I'm sure we'll talk about during this session some very successful work that has already been carried out on medicines management, medicines optimisation, pioneered in the Northern Trust by Professor Mike Scott, but working very closely with a number of software companies, including local Northern Ireland companies. And that may not have led to a headline figure in terms of additional jobs, but provided a real economic opportunity for small, medium-sized software companies in Northern Ireland, and that's something that we're very keen to expand upon.
Okay, and finally for me, and I'm being slightly parochial on this one, but not just about the city, about the region. In terms of North West, and Sean, I think, would be familiar with some of the work that was done around that Health Innovation Corridor. The terms of reference was launched and the Permanent Secretary was in attendance, which was much appreciated. How will that, in terms of the resource that's there currently, and I'm thinking about things like CTRIC, I'm thinking about the Project Kelvin, the University Link in terms of research, how will the department advance that now and going forward?
Yeah, I think, sorry Sean, do you want to pick up on that? Because there has been some developments, but if we can pick up for a few.
I'm happy to make comments, and if I miss anything, Catherine, maybe Catherine could add further to it. And there have already been some discussions, as the Chair likely knows, with colleagues representing the North West about how the Department and Health and Social Care could support the work. And in some respects, it's an identical agenda to the one we've just talked about for all of Northern Ireland. And the more local we can make the effort to ensure that all of the assets that are there, the local industries, the local development in the field of clinical medicine, such as the Stratified Medicines Project at the University of Ulster, come together to demonstrate the opportunity that is available for investment in that area, the better. And I know that I understand there's been some recent progress in actually trying to resource that in it, because it's a hard work to bring people together to talk through what the opportunities are and to set those opportunities out for colleagues in both the private and academic sector.
Yeah, the Minister had recently indicated about a resource in terms of a dedicated either part-time resource being made available, and I don't want to get on the detail of it because I'm conscious it is only one part of the region, but has that been worked up? Has that been developed? It has. Okay, so happy to discuss that after this without getting into the detail.
Very much so, Chair. Well, I'll not go into the detail, but we recognise and we greatly value the initiative that's been taken by local stakeholders in the North West. The Department and our colleagues in the Western Trust are very keen to support that. We listened carefully to what stakeholders have said. What they said is they needed some additional capacity just to provide the coherence, some additional coherence within the initiative, and to allow it to advance its agenda, to avail of the opportunities for funding that are there, either from European resources or from Invest Northern Ireland, in terms of its collaborative network stream. And we're more than happy to make that investment to provide the stakeholders with that capacity that they need, with a view to the organisation becoming self-sustaining in a relatively short period.
Okay, and then finally then, is there a timeline on that? Is a timeline for that resource to be in place?
I can't give you an absolute timeline on that, Chair, but we recognise the urgency of it, so the answer will be as soon as possible.
Okay, I appreciate that. Okay, Gordon?
Thanks, Chair, and thanks very much, folks. Must say I did hear part of your presentation at the health conference at Le Mans. It was one of the sessions there you done on it, and so it was very interesting. We have been to the Centre for Cancer Research and Cell Technology this morning and found it very interesting. What can you do there to help them in relation to drawing down European funding? Or are you engaging with them in the work that they're doing there?
Well, no doubt, when you've been along to there, you'll have heard about the connection that they already have with the Research and Development Office. And we're working very closely with the Research and Development Office. Northern Ireland was a leader in recognising that you need a dedicated office to support the efforts of individual clinical researchers and building networks that help them reach out for funds into Europe, into the Technology Strategy Board, into the Medical Research and Economic and Social Research Councils, because there are many funders. And we are working very closely with the Research and Development Office to provide as much support as we can. But their agenda is really quite strongly developed already, and they have strong links with the cancer research, including the development of the cell technology that is focused in and around Queen's and the Belfast City Hospital. And yes, we work with them to continue to further support that work.
Okay, another issue you mentioned was bringing in change and new methods and equipment. Is that part of your work, or do you see that as part of your work on that day that you we talked about bringing in things in a much sharper, more focused, smarter way.
Yes,
we change new equipment, looking at that rather than going through the long drawn out procurement system that probably you'd wait for the National Health Service to bring it in rather than the trust. Do you see that as part of your role?
I do, yes. So the problem I think that we set out was that right across all of the Western system, from the UK through to America, there's a very long lead time between an idea being demonstrated as having real value and the real capacity to improve health outcomes, and that idea becoming a routine part of how we do business.
I think government has that sort of attitude generally to procuring equipment and new systems and procedures.
I think it's people as well. If you're you know, a clinician freshly educated, you'll know the latest developments. All clinicians seek to educate themselves and make sure they're abreast of the latest developments, but it's easy for a brand new thing to enter the scene and for people not to become aware of that for some time. And that's often the challenge for us. And that's the agenda that we are working on with our colleagues in the Research and Development Office. First of all, to ensure that frontline clinical teams know that we're interested, and secondly, to ensure that we have the mechanisms to respond to them. There are one or two specific areas we could talk about in terms of seeking to ease the burden of procurement. Obviously, procurement is important to make sure we spend public money wisely. But there are initiatives such as the Business Research Initiative, which allows a short timeline to try new things. It makes a promise to go back to the market when you know whether that new thing works, but it means that a small business isn't overly burdened with a, for example, European level bidding process, which can be very expensive to participate in. And the department has very recently sponsored a business research initiative on medicines management. We know that one of the leading causes of injury, avoidable injury to our citizens, are complications in drugs. Basically being unclear about dosage, being unclear about interactions between drugs, and that is the leading cause of avoidable harm to patients. That's recognised again across the whole of the Western world. And the Medicines Management Initiative that Chris mentioned earlier in the northern area has made great strides in that and has been recognised as leading the field in Europe. And we're seeking to build on that at this point by having a research initiative that moves out of a hospital setting and into a community setting.
Chair, if I could just add to that, perhaps with an example that I think it illustrates the power of that mechanism. There is an innovation, a long-standing innovation in Northern Ireland. Members will all have heard of the portable defibrillator, invented in 1965 by Professor Frank Pandridge, literally in the basement of a Belfast hospital. You'd be surprised to know it took 25 years before that became a standard fitting in all ambulances throughout the UK. So the speed of deployment of innovation was nowhere near good enough.
Crazy, isn't it?
Contrast that with the mechanism that Sean referred to, the Small Business Research Initiative, where we've gone from recognising the problem, that there's an issue around medicines optimisation, to going to the market for a solution within months. That mechanism allowed us to go to the market and say, and its real strength is that it isn't straightforward procurement. If it was straightforward procurement, we might have spent a very long time trying to design the solution and then going out and trying to procure it through some very heavy bureaucratic processes. Instead, what we're relying on is the innovation of people within the HSC and the innovation of people out in the market by saying, we're not going to design the solution. What we're going to give you is a very clear statement of what the problem is, and then invite the market to bring solutions forward in a way that is low risk for them, because there are grants available for small to medium-sized enterprises to bring forward their solutions to proof of concept stage, so they don't have to sink millions into research costs that they might never get back. So we quickly get a range of solutions which we can test. The strongest ones then go through into a second phase, and hopefully, and I'm very confident, we will deliver a solution to that in a period of months and certainly not 25 years.
Yes. On that, Chair, are you aware of the new meter that the Southern Trust, Southeastern Trust, have done a pilot on for diabetes?
Very aware of DNAV, and it's a great example. It's an insulin guidance device, which effectively has a lot of the intelligence built into it that you would normally rely on having to sit in front of a care professional to benefit from. There are 150 patients using the system in Southeastern Trust. We are certainly working with them and supporting that. IGEA have established an office in Northern Ireland, so it's small, but it's small numbers of jobs, but they are very hopeful that their product will and we expect that their product will be marketed more broadly across Europe, and are supporting them and working with our colleagues in Invest Northern Ireland. And we're very, very hopeful that the remarkable results we've seen for 150 patients care benefiting, and the core issue, their blood sugar dropping, which is the most resistant factor in the treatment of diabetes. And for all of those 150 individuals, there were some who did not benefit and who no longer use the device. We've seen tremendous results, and we're very keen to replicate that, roll it out across Northern Ireland, and for Northern Ireland then to lead the way alongside that small to medium enterprise who've developed it, and marketing that more widely, which of course would bring jobs to Northern Ireland.
Just finally, on your briefing up at Le Mans, you talked about the work that's going on in Londonderry in the centre there.
Yes.
It's been set up. What, could you just tell the committee what's involved in that? Or?
Well, there's a developing field referred to as personalised or stratified medicines. And broadly, I'm a layperson myself, so I'll do my best to describe it to you. But broadly, it's about gathering up the intelligent information we have on the efficacy of treatment agents, drugs, and a whole range of others, matching those to what we know about individuals, all the way from basic demographic data through to much more sophisticated genomic modelling. We've heard of modelling the human genome to better understand very individualised characteristics, and using the combination of those two sources of information to be able to specify which treatment agent, be a drug or some other treatment agent, works for Sean but may not work for Chris. Understanding how individuals react to some of those treatment agents. And the University of Ulster at the Coleraine campus is one of the centres in the UK that has been funded to take forward that research. So we should be very proud of that. They're well connected into the Western Trust and to the Centre for Clinical Trials and Innovation at Altlingalvin site. And it's one of the strong assets that are available to the Northwest Health Innovation Corridor. Very aware of it, and certainly very keen.
They're committed to it?
Yes, they're through Invest NI. They recognise the potential for job development as well. And most of these things, I mean, the Chair asked earlier about specific job targets, are not quite at a stage where you could say, this is the initiative, this is the size of the market, this is what we've just done, and therefore we expect it'll grow from 10 to 30 jobs. It's more about, I think, preparing the ground for that growth. That's the stage where most of this is at, but we can cite many, many positive examples, and there's a lot to play for. It's a developing field across the UK and Europe more broadly, and our position in it is recognised, as Catherine referred to, by the award of 3-star reference site, standing by the European Union.
Very good. To get everything up in the Northwest, really, it's too much. Thanks very much.
We'd have that debate as well.
Thanks, Chair.
Thank you, Gordon. I think maybe just to clarify that the applications going forward for Horizon 2020, I know you identified the issues around medicine, and particularly amongst an ageing population. And again, it's one of the issues that puts strain almost on particularly our frontline emergency departments. The number of our elderly population who are turning up at A&E because they're sometimes on the wrong medication or a mixture of medication. Is it likely to tackle that specific?
Well, certainly there are a number of applications in that address that heading.
Okay.
The work that's been done led by the Northern Trust, but with significant application in the Western Trust, is one of the core things that earned that 3-star status as a reference site, particular to medicines management. There are other aspects to it, but medicines management is a very strong aspect. Most of that work has been in a hospital setting, so understanding what drugs an individual who's been hospitalised has arrived in on, ensuring that there's a very thorough review, because it can be a very complex process to ensure the right agents are prescribed and that that's effectively communicated to primary care to avoid any confusion or error. And the further work is looking at how to enlist the support. It's already there, but how to maximise the support of our community pharmacy colleagues to ensure that that extends beyond the doors of the hospital and supports people on an ongoing basis when they're in a community setting. So we have elements of that happening already, but we recognise the potential for it to be stronger still.
Okay, I appreciate that, yes.
There's some effect already, Chairman. The committee, of course, will have looked in detail at the many factors that impact on the pressures in emergency departments. But one of them is, of course, the flow of patients into and out of the hospitals. So if you look at the other end, at discharge, and look what we've already achieved through medicines optimisation, something I mentioned when I was last with the committee a couple of weeks ago, average length of stay reduced by 2 days. Average length of stay on readmission reduced by, I think, 5.6 days. Incidence of prescribing errors on discharge reduced from 22% to 1%. All of those things will contribute to removing some of the pressure on hospitals and on emergency departments.
Okay. Okay, well, folks, can I thank you? Obviously, the committee will keep a close eye as the whole, I suppose, theme of connected health evolves. Certainly welcome that you would share the information in terms of specific applications going forward with the committee, so we can just have oversight of that as well. But thank you for taking the time today to inform us. Thank you.
Thanks very much. Thank you.
Okay, members, moving on to item 7, which is a statutory rule, misuse of drugs amendment number 2, and misuse of drugs safe custody regulations 2014. Referring members to page 74. We had considered and approved the SL1 for this rule at our meeting on the 4th of June. Are members content? If so, then I'll put the motion. The Committee for Health, Social Services and Public Safety has considered the misuse of drugs amendment number 2 and the misuse of drugs safe custody amendment regulations 2014 and has no objection to the rule. Item 8 is another statutory rule, the misuse of drugs designation amendment number 2 order. Referring members to page 85. We did consider and approve the SL1 for this rule at our meeting on the 4th of June 2014. Are members content? If so, then I'll put the motion. The Committee for Health, Social Services and Public Safety has considered the misuse of drugs designation amendment number 2 order and has no objection to the rule. Item 9 is another statutory rule, the new Firefighters Pension Scheme Amendment number 2 order. Referring members to page 94. We did again consider and approve the SL1 at our 4th of June meeting. Are members content? If so, then I'm putting the motion. The Committee for Health, Social Services and Public Safety has considered the new Firefighters Pension Scheme order and has no objection to the rule, subject to the report of the Examiner of Statutory Rules. Item 10 is another statutory rule, the Firefighters Pension Scheme.
Many are there of these?
Amendment number 2, Order 2014. It's on page 109. We had again considered and approved this on the 4th of June. Are members content? If so, then the Committee for Health, Social Services and Public Safety has considered the Firefighters Pension Scheme number 2 order and has no objection to the rule, subject to the report of the Examiner of Statutory Rules. Item 11 is the Forward Work Programme. I'm asking members to note the Forward Work Programme on page 136. Item 12 are matters arising. I'm asking members to note items 12.1 and 12.3 on pages 138 to 141. Item 13 is correspondence. Item 13.1 on page 144 is a letter from the Minister regarding a 2-week consultation on proposals to amend the quorum for the Safeguarding Board from 2/3 of the total membership to 1/3 of the total membership. This would be done through amending the existing regulations. The purpose of amending the quorum is to make sure that there are enough members present when other members have to absent themselves because of a potential conflict of interest. This may arise in relation to the ongoing thematic review into child sexual exploitation. The committee will be provided with a report of the consultation report at the end of the consultation period and would then have to formally approve the statutory rules. So are members content to note in the meantime?
Note.
Thank you. I'm asking members to note items 13.2 and 13.3, which are on pages 146 to 150. Referring members to item 13.4 on page 190. Members will be aware that when the Health and Social Care Board met last Thursday to discuss the issue of statutory residential homes, the Board approved the evaluation criteria which the Trust will apply when considering the future function of their statutory residential homes. At the same time, the local commissioning groups have been asked to carry out an assessment of local need for older people's services. In relation to the admissions policy issue, the current arrangements will be maintained until the Trust proposals for change are approved by the Board in the autumn of 2014. In relation to any closures of homes or changes to their use, this needs to be approved by the Board, and the changes would begin in March 2015. However, permanent residents of homes will be able to stay in those homes for as long as their care needs can be met. The Minister has given this commitment. Do members have any views at this stage?
What exactly for as long as their current needs can be met? What does that mean?
I think that's an important point in terms of seeking the clarification. It's through the consultation report. It's referenced a number of times, but it's not clear what, as long as their care needs can be met. So I think we should seek that clarification.
I take it if it's solely that they no longer require, or sorry, they do not require to be moved because they now require hospital treatment or nursing care. You know, there may be that might be appropriate comment, but just there should be clarity there. Yeah.
Okay, thank you, Kieran. Yes.
Just to completely agree and welcome the U-turn by the Minister on this very important issue, which was as a result of people power, I've got to say. And indeed, I must say that in reference to the former Health Minister, he did give a commitment along the same lines, and he carried it out. So I would hope, I'm sure the committee would agree, that the Minister, present Minister, will carry out to the latter.
I'm sure he will.
The promise that he has given us.
The Minister doesn't do U-turns.
Well, he did.
I changed the emphasis slightly. He doesn't do U-turns.
He did a U-turn, and we're very grateful for it. And thanks to the people that stood out and said, don't close our residential homes.
Okay, so are members comfortable to seek that clarification from the Minister about what the definition or clarification on as long as their care needs can be met?
Yep.
Have we asked for it?
I see when Kieran's involved, he will take note.
An outline of that.
Better.
Okay, members, I am asking members to note items 13.5 to 13.6, which are on pages 192 to 222. 13.7 on page 223 is correspondence from the Patient Client Council. They wish to discuss their report on GP services with the committee. Are members content to invite them to the next stakeholders event?
Great. Stakeholders.
Asking members to note 13.8 and 13.9 on page 232 to 233. Item 13.10 is correspondence on behalf of the Beachmount Mums Against Drugs group, who are seeking a meeting with the committee. Again, are members content to invite this group to the next stakeholder event?
Great.
Items 13.11 and 13.12 are letters from WJ Law. Members will recall that the committee recently visited the Pavilions development. Are members content to write to the department about the issues raised?
Great. Now, those of us who were there were very impressed, I have to say. It's a lovely Alex site itself. It's beautiful.
Yes, it was. Item 13.13 on page 254 is correspondence from Let's Talk Crohn's and Colitis NI, again seeking a meeting with the committee. Are members content to invite the group to the next stakeholder event?
Yep, right.
Thank you. 13.14 is correspondence from business in the community in relation to their weight loss programme. They're seeking a meeting again with the committee. Are members content to invite the group to the next stakeholders event? Thank you. Page 257 is correspondence from a Mr. Doherty about health and safety proposals to reduce accidents. Are members content to forward Mr. Doherty's presentation to the department, seeking its views on which agency he should contact to pursue his proposals?
Is he related to Mr. Doherty?
Yes,
Might be one and the same. Might be one and the same.
Absolutely.
Strange pronunciation.
Item 14 is any other business?
Great.
David?
Yeah, Chair, I wanted just to raise one little thing, and maybe Catherine, I might ask her if she would maybe do a little bit of background on this. I'm a little bit concerned just that there was maybe a little bit of misleading of the committee from somewhere. It's why I was questioning the Human Rights Commission quite directly about the issues of how the report was instigated, and it really is just a matter of accuracy more than anything else, because the Human Rights Commission were quite, explicit in the fact that it was a unilateral decision as far as Human Rights Commission were concerned. However, in a exchange of questioning between yourself, Chair, and the Right Honourable Mr Dunn to my right here on the 4th of June, there was an indication given that that was maybe not necessarily the case, that there had been some involvement from yourself as Chair in requesting that. So maybe I could just ask Catherine just to check the record just of that exchange that took place first of all, and perhaps maybe come back to us. I think we just want to get clarity on the issue, just as to where, There's nothing for the Human Rights Commission to be ashamed of if there was a request from within this committee to such a report.
Probably let me clarify it now. In answer to Mr Dunn's question at the committee, I was very clear. Now, whether that has been misinterpreted or taken up differently, but I was very clear that there was no role that I or anybody else had. And Mr Dunn asked me, in light of my comments in an Assembly debate, had there been any intervention to the Human Rights Commission, and I was very clear that I said no, there hadn't been.
Well,
that the Commission initiated, and I was very clear, the Commission initiated this process.
And just with respect, Chair, I'm certainly not questioning your authority on that, but I had also checked it for the record as well, and that's why I'm suggesting maybe an independent look at it. Because Mr Dunn had asked, was it your own initiative directed towards you that started, and I'm paraphrasing somewhat, and your response to that was that it was. Initially, he had asked who initiated the action, and you had, as you quite rightly state, said it was the Human Rights Commission. He then followed up with another question, was it your own initiative that started the process? And your response to that was it was. Now, that may have been a misinterpretation of the question that was being asked, and I'm completely open-minded to that, but just for the point of accuracy, I think it's important to have it on the record, because as it stands at the minute, we have some sort of a recognition from yourself, whether rightly or wrongly, or interpreted or misinterpreted, that there was.
Well, happy to clarify that. Happy to go back to the record, and I don't know what record you're checking on it, but certainly I've clarified the situation as I stated it at the meeting. It certainly was no intervention from myself or anybody else that I'm aware of. Okay. And I thought I was perfectly clear in response to Mr Dunn. I know that the question was asked around my comments in the Assembly chamber, and I did make comments around the Human Rights Commission because the work had been initiated that day of the debate, was very clear on that, but was also extremely clear, and happy to go back and double check it, that the Commission initiated that process.
Yeah. Well, it's there, I think, 2 minutes and 29 seconds into the recording, so the record is there, and as I say, I think it's if that is the case, well then great, let's get it on the record. But one side or the other of this has obviously made some sort of an error in judgment on what they've said.
Happy to go back and clarify. Stand over any comments?
I have to say, Madam Chair, I left the meeting with exactly the same impression. I mean, a powerful woman that you are, I realise as Chair of the committee, I thought maybe you had instructed them to do it. And I mean, I wouldn't have taken any offence if you had, but I'm just saying I got the impression it was you'd ordered them to do it.
Okay, well, happy to go back and clarify that.
I got the impression that you had asked them to do it, but maybe they independently decided to do it. Whatever. That was the impression I took.
Okay, well, again, happy to go back to the record and clarify that, but, I am being specifically clear on what I said, and I know the question was raised, and I reiterated again today that what I said was the Commission had initiated the process. Okay.
And Chair, just to be clear, in terms of David originally asking me as clerk to check the record, there isn't a written record. That part of the meeting is not Hansarded. It is on the listen again, the play again, which obviously some of you have already accessed. So there isn't something that I can go, something else that I will go and check. There isn't something else that I will clarify.
I'm not sure where we're going with this, because someone as individuals, you can ask anybody anything, you know, but it's, if they did it as their role as the chairman of the health committee, that'd be different, but that was never said, I'm aware of.
No, it's just that that's not the issue, and I agree entirely with Mr. Wells on that. I mean, regardless of how this report came about, I think is an innocence. I suppose what I'm just concerned about is, as it sits at the minute from the accuracy point of view, there has been there's just contradictions. There's just, the Human Rights Commission were very explicit in saying absolutely not, we had no interference, but yet, and I take your point, Calvin, I mean, I have checked the record, and Madam Chair, with respect, you do answer that it was, it very clearly is there. So it's really just to, you know, if the meeting of the 4th of June needs to have some amendment or clarity to it, then so be it. But I think as we stand at the minute, there has been a misleading of the committee, albeit probably unintentionally, but there has been.
Okay, well, happy to clarify that, as I've stated. Item 15 is the date and time of next meeting, which is on the 25th of June, starting at 2:30. It'll be a different time in the Senate chamber here. So thank you, members.
This is the Northern Ireland